Hello, everybody. My name's Ketan, Dhatariya, and I'm a diabetes consultant from the Norfolk and Norwich Hospital in Norwich. I'd like to thank the organisers for inviting me to give this talk, which is about euglycemia in acutely unwell inpatients. I'd just like to start with my disclosures and move on. Now, the definition of hyperglycemia in the hospitalised patient really depends on what you read and who you read. And there, of course, the two big organisations that look at inpatient diabetes are the American Diabetes Association and the Joint British Diabetes Societies for Inpatient Care. And of course, I'm the chair of that latter organisation. And you can see here from this slide that the ADA says anybody who's got a blood glucose above 7.8 millimoles per litre should be defined as having hyperglycemia. Whereas in the UK, we say that anybody who's got a blood glucose, well, the ideal blood glucose should be between 6 and 12. Unless you've got a end-of-life person where you can be a bit more liberal so they don't get symptomatic hypoglycemia or symptomatic hyperglycemia. So the ADA says that you should, if you have somebody who's not known to have diabetes and they get hyperglycemia and yet their HbA1c is within the reference range, and they can be diagnosed as having stress hyperglycemia. So the question really is there any evidence of harm from low or high glucose concentrations in inpatients? Of course, the answer is yes, because there's loads and loads and loads of observational data to show that that is the case in many different specialties, in many different times during the patient journey. So let's talk about what happens to the front door and if there's any evidence to show that harm happens to people when they're hyperglycemic when they come through the front door. And I just want to share with you some information that we published a few years ago now in Clinical Medicine in 2012 that looked at every single hospital admission that came through the front door of the Norfolk and Norwich Hospital during February of 2010. And we had over 1,500 patients that came in, and we assessed many different things, essentially relating them to the admission glucose concentrations. And what we found was that if your admission, the higher your admission glucose, the longer your length of stay, except in the very highest individuals. And the reason for that is because at the Norfolk and Norwich, we have a specialty triage system where people who are particularly hyperglycemic tend to be admitted under the diabetes team, whereas everybody else is scattered amongst the most appropriate team for their admission. They just happen to have hyperglycemia in addition to whatever else they were in for. So there's a strong trend towards a length of stay with admission glucose. We also looked at readmission rates, and of course, even under the endocrine team, if you had a high blood glucose, you are much more likely to be readmitted within 28 days compared to those people who had a normal blood glucose concentration on admission. Similarly, 28-day mortality was significantly higher in those people who were admitted with hyperglycemia. If they come into hospital, and of course they go into intensive care. Now, intensive care is the area that's probably studied the most in terms of glucose concentrations and outcomes. This is a very busy slide, but really I just want to show you this is a systematic review on glycemic targets and outcomes in intensive care patients. And really there are three different outcomes that this group looked at. You can see short-term mortality and the development of hypoglycemia, or the development of severe hypoglycemia, of course, requiring third-party assistance. And really what I will show you is those situations where the studies that compared tight glycemic control with either very mild or mild, i.e. liberal glycemic control. And what you can see here, if you look at the relative risk column second from the right, that in the red you can see that it's a 5.64 relative risk increase, almost 5, 5.5, and 4.5. So almost a 5-fold increase of hypoglycemia in those people who were treated with tight glycemic control. And I don't need to tell this audience that actually having hypoglycemia in hospital is bad for you, because it automatically almost certainly increases the length of stay, increases in hospital mortality, and so on. And that's been shown beautifully by my colleague Andrea Lake and colleagues in their systematic review published in Diabetic Medicine a couple of years ago. But also, this is again a busy slide taken from a particular publication, but I want to show you about the variation in recommendations from around the world. And in this second column here, you see under glucose control recommendation, there are lots of different targets, so 140 to 180, so it's 8.7 or 8.6 to 10 millimoles per litre. Similarly, for people with diabetes on ITU, if you're depending on what your HbA1c is, it could be down to 140 milligrams per deciliter, which is about 8.7, up to 11 if you've got an HbA1c greater than 7 or 53 millimoles per mole. Surgical ITU, of course, this is one of the things that was shown on one of the papers from Greet van der Bergen colleagues. You're going down to less than 150 milligrams per deciliter, and again, about 10 millimoles per liter in neuro ITU if you've got MI. So there are variation in the targets set for people on intensive care. And effectively, the reason is because there are no randomized controlled trials out there. And these are a summary of what people have put together and thought this is what we ought to be doing in the population that they're looking after. And again, a bit more. This is just a summary. The American Diabetes Association on ITU, Canadian Diabetes Association, Society for Critical Care Medicine, and you can see all of these individuals. And the bottom one here is the Research Society for Diabetes in India, which again all come up with the same thing, saying the treatment threshold should be if your blood glucose is 10 or more millimoles per litre, but the target glucose varies. I'm sorry, my photograph is covering the bottom two there. So there are variations. And I think this this quote beautifully summarizes what's going out there. The ideal blood glucose target remains unclear and may depend on the context. The main problem with the studies that we have is that there are no randomized controlled trials. It's all observational data. It's all retrospective data with very few prospective trials. And the prospective trials that have been done on intensive care, such as the two papers from Greet van der Berg, the original one from 2001 and then in medical ICU, and the subsequent one on the surgical ICU. And then, of course, the largest study done on ICU, which was nice sugar of over 6,000 patients, showed that, in fact, the latter showed that tight glycemic control was associated with a much higher incidence of severe hypoglycemia and increased mortality. So we actually don't know the answer for what is the ideal glucose level in acutely unwell inpatients on the ITU. But let's move on to a different subject. Is there an ideal glucose for somebody who's undergoing surgery? Well, the answer is, does perioperative glucose cause harm? Yeah, of course it does. And many of you may know that I've been involved with the inpatient and perioperative diabetes care for many years. And this is just a small sample of the studies that have been out there. Again, almost all observational to show that either HbA1c or glucose concentrations are associated with harm if they are high in all kinds of different surgical specialties. So the question is then, what is euglycemia? Well, these are data all the way back from about 2001, looking at, again, front door admission glucose and what is mortality. And they showed that the safest glucose concentrations were about 4.3 to 5.6, so i.e. people who didn't have diabetes or where glucose was effectively normal even when you were acutely unwell. So you didn't have stress hyperglycemia, and perhaps that's intuitive. And perhaps what we ought to be aiming for is glucose concentrations this low, however they are achieved. But the difficulty, of course, is how do you achieve them? Intravenous insulin infusions can be very well used if the staff are there and they're trained to use them properly. But unfortunately, in busy front door departments or busy wards, when staffing levels are not as good as one would like them to be, then there is the risk of developing hypoglycemia. There is, of course, the new technology that's on the horizon, which is the use of closed loops in hospital systems in patients. And there are a number of studies that have been done mainly in the UK, actually, to show that in closed loops in hospitalized patients do maintain time in range and excellent glycemic control. But the long-term outcome studies looking at the large numbers of people to show that actually it does reduce length of stay and does improve outcomes has yet to be shown. Really, most of the studies at the moment are just proof of concept and safety studies. And so those data are awaited. I want to just touch on that issue about hypoglycemia. So one of the things that the Joint British Diabetes Societies for Inpatient Care has really been talking about is we've shifted the bottom of the reference range. Whereas many of you may know, we used to say the ideal range is 6 to 10 with an acceptable range of 4 to 12. Now we've moved away from that. And the reason is because we realized that if somebody's aiming or has got a blood glucose concentration of 4, then a well-meaning healthcare professional, healthcare assistant or nurse, whatever, if the trend is already going down and you've got a glucose of 4.4, 4.3, 4.1, over the 2 or 3 hours, then actually they say, well, it's 4.1, it's fine, it's not going to go anywhere. And of course, the next time they do it, maybe a couple of hours later, it's down to 3.7. And of course, that's hypoglycemia, and then that makes prognosis that bit worse. And the increased risk of harms increases. So what we've said is actually the bottom layer of the target should be 6, but 4 to 6 should be thought of as looming hypoglycemia, and action should be taken to prevent the glucose dropping any further. And so in Norwich, we produced this chart, which many of you may have seen, and we've shown previously that actually having a coloured chart does reduce the length of stay, does reduce harm, does reduce the length of time that people have to use a variable rate intravenous insulin infusion. But of course, this may be superseded by the use of electronic prescribing, and whether there's a link between network meters and electronic prescribing systems. I appreciate that that's not available in many hospitals, but it is the horizon, it is the future. And there may be that inpatient diabetes teams will be able to target those individuals who need to be seen or at risk of developing hypo or hyperglycemia to prevent harm from happening to them. And so I'd encourage you, if you do have a system, please publish it somewhere, because the data are lacking and we need to show that these technologies do improve patient outcomes. So I'm coming to the end of my talk. Really, I've been through this before, but euglycemia is the glucose concentration that is associated with the least harm. I mean, I know that's probably, I'm trying to dodge a bullet there, but nobody knows what the target is. And I think in the UK, we say that the ideal target should be between 6 and 12. And in end of life, as I've said, it should be 6 and 15. But nobody knows the answer. We're waiting for you to be part of the team that answers that question. Thank you so much for your attention. I would just say, if you want to ask me any questions, there are my contact details. Follow me on Twitter, and this presentation will be on this website in due course.